it, what to do.
I'm keeping it quite informal. It's quite chatty. It's lots of little tips, but like how I talk to patients, things like that, rather than it being clinical.
That'll be brilliant as well, because I think that'll keep everyone entertained. And as we are live now, I hope the audience are listening, and we are on to Tubules Live, talking about one of the most important topics. Hey, I will say it's most important. I may be biased, as will be our speaker today, because we're both periodontists. It's not always I get to host a periodontist, so it's really good to have all that. But if anybody has any questions, any queries, anything at all, please feel free to type your questions in the box below. Every week, we do this every Monday. We do this every Thursday. Tubules Live comes to you from our homes at the moment, but it looks like good news in the UK. Things are beginning to open up. But while this happens, we'll continue to, power you with education and knowledge. Before we start, always an introduction. Always about welcoming you to Tubules Live and telling you to power up your V6 engines, getting your engine fired up, get your wine, your coffee, your dinner, whatever you're doing, because we start and end your week with inspiration, positivity, enthusiasm every Monday, every Thursday at 7:30. Now, let's start with a thought. I always start with a thought. Last few months, I've been asking two questions. Question one has been, what's your definition of success or thriving in dentistry? And question two has been, why do you learn? Because do you know what? We all have a certain kind of goal in our head. Whatever you do, we all have goals. We all have these aims and needs or desires or a wish or something we're trying to meet every time. Whether it's you waking up and having a goal to brush your teeth, or whether you getting to work and having a big goal of achieving something, that's where your definition of success lies. And the second thing is that we're always trying to figure out where we are and crossing the bridge, what jigsaw pieces we need to make the goal. That's the plan that we're all making. And why do I say this? Because most of us are creating these goals in an automatic mode. We don't recognize it. And the second thing is that what you learn and why you learn most of the time is part of this plan, whatever the plan is. That's why you're here to learn. You're here to gain knowledge. Knowledge is going to help you in your plan that you want to reach, whatever goal it is that defines your version of success. That's what you're doing every single time. But what I'm saying is knowledge and learning is one of 5 pillars in that journey. You need to understand and know your goals or your goal or whatever it is. You need to have knowledge. You need to develop the skill, have the right environment to apply it, and have the right community, the network or tribe of people who will positively inspire you, who will encourage you, who will support you, and who will get you the resources to help you get those goals. That's what it's about. And if you can make that plan well, that's where it goes. And then you grow and improve day by day, little by little. That's the process of growth. And that's how you reach your goals and increase your chance of thriving. And why you're here to learn and how we can help you at Dental Tubules. We help you find those inspiring goals with our IPDP. We help you grow to achieve those goals. That bridge you cross, I talked about the 5 pillars you need. Those 5 pillars are on Tubules, whether it's the direction you need with your IPDP, whether it's the knowledge. We have over 2,000 online videos with I'm now told we're reaching nearly 60,000 minutes of learning. We give you skills because we run courses and partner with course providers. The environment with over 400 practices who use our practice membership. And we have a community with study clubs, with nearly 52 study clubs around the country in the UK alone, and 47,373 members worldwide now, with so many study clubs. The 5 pillars of growth you need. That's how you maximize your potential to thrive. Inspire, grow, thrive. And don't do it alone. Inspire, grow, thrive together. And that's when you can encourage your teams and your practices to use the 5 pillars of practice growth. And that's Tubules. Inspire, grow, thrive together. And we give you CPD. Yes, we give you IRMA. We give you everything you need that is needed for education. But beyond CPD, beyond education, I repeat, it's about inspiring you and your teams, enabling your teams and yourself to grow, and giving you and maximizing your potential to thrive. And not just growth in professional areas. Yes, our Tubules Live cover professional, but we give you knowledge in the financial or economic and personal growth, because it's that triumvirate all three together side by side that help you reach your potential. And that's why CPD as continuing professional development is what others do. For us, CPD is about you as a complete person development. That's what Dental Tubules is about. That's why we're an organization of 47,000 tubulites, inspiring, growing, thriving together every day. Students, undergraduate students worldwide get free premium membership in Dental Tubules. And this has been our, lineup, our teaching, our live streams since January. Personal development, oral surgery, ownership, orthodontics, prosthodontics with all the speakers you saw earlier. April was all about the digital month, and May has been about the restorative-based topics, endodontics, and so on and so forth. So if you like what Tubules does and if you love what we do, share and spread the Tubules word, because the world needs the tubulitis. Facebook, WhatsApp, Instagram, email, talking to friends, whatever it is, share it, because we need to get people inspired and energized. That's what we stand for. Yes, we have all this video library. Yes, we have all the community and study clubs. Your job, you decide. You can remain an isolated sheep in an isolated farm, or you can join the tribe of Tubules tigers, positively trying to make a difference in dentistry. And not just dentistry, Tubules makes a difference around the world. 3% of our growth from Dental Tubules still goes to the Tubules Foundation that helps to build schools and educational facilities for little children like this around the world. They don't have facilities. Look at these kids here. This was their teaching. This was their lunch area. This was everything. And this school needed a library. We have put close to £65,000, I think, now to help get this library a reality. These kids who wouldn't have a chance, we're building an IT suite there. The library building's complete and the insights are being done, and we hope that in the next few months it'll be ready and making a difference. And we hope we make a difference to you today with the education. With that note, we welcome you to today's event with Dr. Geeta Outplish, a specialist in periodontics, who will give you some top tips for root surface debridement in practice and share her experiences. Before I invite Geeta on, I'd just like to talk about the fact that CPD is available for this evening for premium and practice members. You see the video where you're now. Below the video, you'll see a little chat box where you can put your questions in. If you can hear me, please type on there as well. Below the chat box, not yet, at the end of the webinar, you'll see the verifiable CPD. Click on yes and answer the multiple choice questions. When you've answered them, click on submit questionnaire, but don't stop, carry on. Click yes and type the reflections in. After you've typed reflections, click next and carry on to tick your IPDP goals, which will be periodontics today. Click next and then put your GDC high level outcome, which will be C for today. And finally, answer all the CPD feedback survey questions. If you don't do all of these steps, you will not get your CPD certificates. If you do all these steps, then the CPD will automatically be generated into your account and certificate will be formed. You'll get a confirmation box like this. You can then go to your IPDP. You can click on IPDP quick links and click on CPD certificates, and you can then print your certificates as needed. For the base members, if you're not a premium member, enjoy tonight's live stream. We share the knowledge at no cost. If you do want CPD, you will need to go down at the end of this evening's live stream and click on upgrade now, and then you can upgrade. Students, it's free for you. Hygienists, therapists, technicians, nurses, there's a special rate. You click on apply now. Dentists, it's £250 per year, or you can choose the £70 a quarter, or if you want, you can have the practice membership. And if this is the first time you're upgrading, we'll take your card details, but we will still not charge your card immediately. We will still give you a 14-day trial to test drive the website, the growth engine. But what we know is after those 14 days, most people convert, because once you're tubulized, you don't look back. I hope that's a great introduction, and that's enough of me. I'll ask our speaker to unmute, and welcome to this evening, Geeta. Sorry, there we are. Yes, we can hear you now, I think.
Hi, Drew. Thank you. Thank you for inviting me to speak for you.
And thank you so much for sharing your evening today. It's a nice evening today. And you know what? You'll agree with me. This is the most important topic in dentistry, periodontics, how you manage patients.
Absolutely. I agree 100%.
Now, before I start live, I always ask one question, and that's the only question I'll ask of you. Who or what inspires you?
That's an easy one. My father-in-law inspires me. He was a dentist owning his practice for 50 years. Dentistry was his life and his passion. It still is, but sadly, COVID and too much PPE took care of his practicing career. But at 81, it wasn't a bad time to stop. But yeah, he's a very inspiring guy because
You know what? I'll
world.
concur with that because I remember him. He has a passion for dentistry. He
Yes,
always tells me I'm a cardiologist, and he wrote a book, I remember,
it's
and he
true.
always carries his camera around.
It's true. Absolutely. Absolutely. I'm also very fortunate because I get to work at King's with an incredible team in the hospital. The whole restorative department's amazing. My practice up in town, I've got an incredible team. And my husband's father's practice that we've now taken over, they're also such a wonderful group of dentists and nurses and hygienists. So I'm very lucky to be working with some brilliant people.
And we're looking forward to you sharing your wide range of experience in all these environments. I'll be happy for you to share screen so we can start this evening's presentation when you're ready. Yes, we can see that. Your presentation's good. I'm going to stop mumbling along. It's Dr. Geeta Auplish talking about the top tips for successful perio treatment in practice. Over to you, Geeta. Thank you.
Thank you. Good evening, everyone. Thank you for joining me on this lovely, sunny Monday evening. What I wanted to say is to give you my top tips after being a perio specialist for 20 years, a dentist for 25 years. A lot of what I'm going to be telling you about is the lines that I've honed over the years that work for my patients. I want this to be practical and useful, chatty, sadly not interactive, but just informal, so that I can just tell you what I think has worked and hasn't worked, both clinically and again some of the communication lines that I've used with my patients. I started out with Manny Vassant, who many of you may know as his VT, and worked with him for a year as his associate, and then very quickly realized I wanted to specialize. So I went to the Eastman to do my master's, and I then stayed on faculty there for 14 years till I became a consultant at King's, where I teach the SPRs, the SHOs, MClinDent students. So all this time I've also worked in private practice. So I've had quite a varied career over the last 20 years of being a perio specialist. So to start, my next slide. Let me just see how I do that here, maybe. Perfect. Okay.
Yeah.
So thank you. So the majority of gum diseases are preventable. And I wanted to really highlight this poster because, as you can see, it's by the European Federation of Periodontology and the British Society of Periodontology to highlight Gum Health Day, which is the day after tomorrow. It is on the 12th of May, it's on Wednesday. And this is their key message that they're trying to get across. Periodontitis is the most common chronic inflammatory non-communicable disease in human beings, and it's a major public health problem. And research has shown that patients either stop brushing or brush less when their gums bleed. And 82% of patients think that bleeding is benign. So it's very important that we get this message across to them. And the key to that is communication, and for them to also improve their oral hygiene, because nothing we do is going to work unless their oral hygiene improves. And if it does, then with our treatment, gum diseases are very much preventable. I want to start with just doing one case example from the new classification, so that when I'm talking about clinical cases, we're on the same page in terms of diagnosis. So I'm going to highlight the periodontist section. And for the periodontitis, we have 5 key statements that we need for a diagnosis. We need to first say whether the periodontitis is generalized, which is more than 30% of teeth, localized, which is less than 30% of teeth, or whether it has a molar incisor pattern. Our second statement is the stage. The stage is 1 to 4, 1 being mild and 4 being severe. And the grade is A to C, where A is a lower risk and C is a higher risk. We then need to say whether the condition is stable, unstable, or in remission. And finally, we need to discuss the risk factors that are associated with this. The BSP, as you have all seen and you all know, have produced this fantastic flow diagram that will help and lead us through to get to this classification and diagnosis. And you can see, as you're familiar with this chart, if a patient has a code 4 in BPE, then this is where we get the distribution of whether it's molar incisor, localized, or generalized. The other side of that chart that they produced is the staging and the grading. And this is what I was talking about earlier. If a patient is stage 1 on the worst affected tooth, they've got less than 15% bone loss. If they're stage 2, they're moderate, and there is coronal third bone loss. If they're stage 3, that's severe periodontitis, that's middle third root bone loss. And if they're stage 4, that's very severe. We have apical third bone loss. Once you have your stage established, you can determine whether the grade is A, B, or C. Most patients are a grade B, which is a moderate rate of progression. An easy way to work it out is if your bone loss is more than your age, you're a grade C. You have a rapid rate of progression. If your bone loss is less than half your age, you're a grade A. So you have a relatively slow rate of progression. We then determine whether the patient is currently stable, in remission, or unstable. In order to be Let's go to unstable. In order to be unstable, you simply need a pocket of 5 millimeters or 4 millimeters that's bleeding. Most patients you'll find are currently unstable, although it is possible to be stable in remission. Generally, we're looking at most patients being unstable if they have been diagnosed with periodontitis. And the final section, number 5, is the risk factor assessment, which is usually something like smoking or poorly controlled diabetes. So we'll do one example now just to give us a diagnosis. And we have a 49-year-old female. She's medically fit and well and has relatively low stress. She smoked back in the day, but hasn't smoked for a while. And she's had multiple root surface debridements with her GDP under local anesthetic. She does have probing depths greater than 4 millimeters and has furcation involvement. A 6-point pocket chart looks like this, and you can see here, if we take the upper right 5, for example, we have pockets of 6, 7, and 8. If we take the lower left 5, we also have pockets going up to 9 millimeters. There's quite a lot of bleeding that's around, and you're trying to assess here the number of teeth involved, and if there are more than 30%, then it's generalized. So to come up with a diagnosis for this patient, we need to look at her x-rays. And if we look at her x-rays, we're trying to establish which teeth have got the most bone loss. And you can see from this series of long cone periapical radiographs, the teeth that seem to be most affected are the upper right 5, which you can see here has extensive bone loss up to the apical third. The lower left isn't that great either, the lower left 5. So we've got a lot of bone loss, particularly in those areas, but there's bone loss all over. So we go back to this brilliant chart from the BSP and we establish the stage and the grade, and we then also stability and the risk factors. So first question is, we're asking, is this generalized or localized? In this case, because more than 30% of teeth are involved, it's a generalized periodontitis. The stage, looking here from the CEJ to where the bone is and to where the apex is clearly a stage 4, which is very severe because it's got apical third bone loss. The grade, she was 49 years old, and we call that a grade C, which is a rapid rate because she has bone loss greater than her age. She has 90% bone loss, which is greater than 49, which is her age, which puts her over a ratio of 1 and a grade C. So she has a rapid rate of bone loss, and that's a grading C. She's clearly unstable with the amount of pocketing and bleeding that she's got. And her risk factor particular to her was she was an ex-smoker. So to my top tips, now that we've established what the diagnoses are and the classification, I wanted to start with what I think is a very important message. Once a perio patient, always a perio patient. And it's a lifelong condition. We need to insist that patients that have a lifelong condition have maintenance maintenance, maintenance, either with yourself or your hygienist and therapist. And I can't emphasize that enough, because it doesn't really matter what we do in terms of non-surgical treatment, surgical treatment, regeneration. Nothing is going to work. All our evidence shows us that nothing is going to work unless we have regular supportive periodontal care. And the frequency of that SPC depends very much upon the patient's individual susceptibility. So it's a lifelong condition. And if someone is highly susceptible, I would say 3-monthly supportive periodontal care is absolutely crucial to disrupt that biofilm that patients can't necessarily do as well as we can, obviously, on a daily basis. And like everything, prevention is better than cure. My next top tip is to emphasize that treatment success is a partnership. The patients need us, but quite frankly, we need them. So one of the lines that I will say to patients regularly is, I'm going to remove the hard deposits underneath your gums that you can't. I'll say it's like lime scale in a kettle. You can brush it as much as you like, it isn't going anywhere. But you have to effectively, and the key word is effectively, remove those soft deposits twice a day, every day. I don't live with you. Right? We need each other. You have to be able to do that side of it, because otherwise whatever I do isn't going to work. And so it's about communication of oral hygiene, of risk factors, smoking cessation, good diabetic control, stress. It's a really big communication that's involved with successful treatment in perio. And this is quite different to, say, having a root canal treatment. A good root canal treatment is often really just operator-led, provided the patient's fairly compliant and can open their mouth and have it. Their input to whether the endodontic treatment works really depends on the skill of the endodontist. So that's why I think perio is quite different. You'll hear me talk a lot tonight about communication, because I need the patient as much as they need me in order to get a successful outcome. Dentistry needs to be cleansable. You can see here we've got some subgingival margins. That's where we come into play. The treatment success depends on us providing good cleansable dentistry and then providing good home oral hygiene. Right, this shouldn't be controversial, but I wanted to emphasize it because I understand that patients don't particularly like being disclosed, and dentists and hygienists don't necessarily like disclosing. I think that they feel that patients dislike it more than they do. If provided it's done sensitively on a cotton bud and around, they work as a fantastic motivational tool. Patients can clearly see their new and mature plaque that's highlighted beautifully by the disclosing solution. And also plaque scores as percentages. I will say to a patient, right, here's your plaque score today, you're at 45%. We need to get this lower than 20%. Next week, this is what we need to work on. And next week, when you come back, we're going to be checking it again. They come in and they go, what's my number? And it takes a very, very short amount of time to do a plaque score. Obviously, it's much easier if you have a nurse, but it's just a 4-point score. I tend to start on the upper right and I just do distal, middle, mesial, all the way round. And then I come back on the palatal surface. So I'm just calling out to my nurse, yes, yes, no, 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 yes. And she's just putting a little cross when I'm saying yes, and then you get a percentage. And I just think they're fantastic to help motivate patients. Now, it seems obvious. It seems obvious to us, I think, but healthy gums don't bleed. And it continues to be surprising to me how I would say the majority of patients think that bleeding on brushing is normal or is due to them brushing too hard, as opposed to it being, as we know, inflammation. So I will literally say this line to patients, healthy gums don't bleed. And if it's bleeding, brush more, not less. You almost need to give them permission to actually brush and clean more, because they're scared to brush when they see blood. Patients are scared of seeing bleeding. They're like, oh, it's bleeding, better stop brushing. It's the exact opposite. You need to be cleaning more, not less. And we need to explain to them that this is not normal and this is not healthy. And therefore, we need to really encourage them with patient education that it's not acceptable and we can get the bleeding to stop. Again, this is a message that Gum Health Day in 2 days' time is trying to explain and get get this information out in a public health forum and domain so that it becomes basic knowledge, which I genuinely don't think it is at the moment. So this very powerful image of an apple being bitten into with the blood there and saying, say no to bleeding gums. So it's really important, because emphasizing this public health message is essential, because it impacts upon social and economic burden, on tooth loss, on general health, on quality of life. It all has an impact. Susceptible patients, and by that I mean grade C, so high risk where their bone loss is higher than their age, have to have excellent oral hygiene. And again, forgive me if this seems obvious to us, but it isn't actually obvious to patients, because they'll be like, oh, but you know, my partner, my husband, my wife, my next door neighbor, right? They can get away with not brushing every single evening, or not using an interdental brush or floss or something. And that's probably right, you know, like, but 10% of the population are highly susceptible to periodontal disease, have what we used to call aggressive periodontitis. And quite frankly, a little bit of plaque in their mouth has a huge detrimental effect, which will be quite different to their partner or their friends. And if they are highly susceptible in their grade C, there are some additional things I think that are important to consider as part of your overall management for them, such as screen the rest of their family. We know that this has a very strong genetic predisposition and family history. So it's important to screen blood family to check for their susceptibility as well. Consider using things like systemic antibiotics in these very aggressive periodontitis cases. Because the disease is more aggressive, we need to treat it more aggressively. So this is one of the few times where we would really consider using systemic antibiotics as part of our overall treatment and therapy for them, even in the initial stages. I'm not the biggest fan of chlorhexidine, but there definitely are times where it has an important role. And I would say in this grade C type case, adjunctive chlorhexidine definitely has its place. And this has also been shown in all of our studies. The key word here is adjunctive. You're using it as well as everything else you're doing within your armamentarium to try and treat this periodontitis. So it's not instead of doing anything, it's as well as, it's adjunctive. And these patients have to use interdental brushes every day, ideally twice a day, because a little bit of plaque in their mouth has a bigger effect, especially in times of immunosuppression, stress, emphasizing to them that it's a lifelong battle. And quite frankly, they'll be dealing with this for the rest of their lives, and their cleaning does have to be better than everybody else's. And they do have to have supportive periodontal therapy every 3 months. Right. How many times do you have patients that come and see you and they go, but I brush 45,000 times a day, and I use this and I use that? Okay, I'm sure you do. I'm not calling you a liar, but it's not what you use, it's how you use it. We're going back to the word effective cleaning. And it doesn't really matter whether they're using an electric toothbrush or a manual toothbrush. Our new guidelines have shown us on paper they're equally effective, and it's a recommendation to use an electric toothbrush, but you can brush very effectively with a manual toothbrush. But effective is key. Okay, and that does involve us taking the time to show them the correct angle, the 45-degree angle, to place the toothbrush at the gum tooth margin, and to use the correct motion with the manual toothbrush or holding an electric toothbrush still. My personal favorite thing about whether we're using a manual or electric toothbrush, and why I particularly like an electric toothbrush, is very simple. There's one thing I love about the electric toothbrush more than anything else: the timer. The timer will buzz usually every 30 seconds for 2 minutes. So you're brushing for 2 minutes. Now, our studies have shown us that patients that are using a manual toothbrush think they're brushing for 2 minutes, but in fact, they're brushing for significantly under 1 minute generally. Okay, so it doesn't matter whether they use a manual or electric toothbrush, but if you find an electric one is more motivational and it has the timer on it, which I love, we need to show them the correct technique so that they're using it appropriately. For a periodontitis patient, interdental brushes are essential, absolutely essential, and better than floss. We know this. We've seen all the research. We've seen the crazy headlines in the Daily Mail that was talking about how we don't need to floss. Massively misleading, obviously. But interdental brushes are better than floss for one reason. There are different size spaces between all of the teeth. And I will say to a patient, you need a rainbow of colors because of the different size spaces between the teeth. One size does not fit all. I'll say something like, because my husband's such a big golfer, it's like golf. You need a different club for a different shot, okay? So my hygienists are wonderful, and what they will do is they will go over with their mouth, tailor-made, showing the patients which color they need in which space. It needs to be snug. It shouldn't be forced. But if it's pretty loose, that's just going in and out in between the teeth, it's really not removing the plaque like you're hoping it does. So the line I use for patients, my top here, is say, you need a rainbow of colors. Okay, again, slightly controversial here, but I have been heard many a time, both from my students and my patients, to say mouthwash is like using a perfume or aftershave when you need a shower. I love perfume, but I don't wear it instead of having a shower. I wear it after my shower because I like it. So the problem is, as you know, a lot of the adverts on TV can be quite misleading, and they are implying that using a mouthwash alone will actually kill 99% of the bacteria above and below the gums. The bottom line is these antiseptic mouthwashes have a role. They absolutely have an adjunctive role in these susceptible patients. The concern comes when they are using them instead of interdental brushes or a 2-minute effective toothbrushing technique. The one thing I would emphasize is for these patients that it is useful for them to use a mouthwash. They should be using the 0.2% chlorhexidine. Now, the daily one that's come out recently is 0.06%. And the reason they brought that out is because it has less staining and less of a taste disturbance. People don't like the taste too much, the 0.2%. It's not proven to actually do nearly as much as the 0.2%. So if you're going to be recommending chlorhexidine, please recommend the 0.2% one rather than the 0.6%. So I'm all in favor of complementary therapy as well as, but I'm not in favor of alternative therapy. This must not be used as an alternative to anything. So how do we do effective debridement? This is where we sort of get stuck in. 2 things. You need time and you need local anesthetic for a periodontitis case. And again, this might sound quite simple, but if somebody is not susceptible to periodontitis, which is about another 10% of the population, then fine. But if somebody has a severe form of periodontitis, you need time to remove a huge amount of subgingival calculus that's wrapping 360 round teeth. And it's uncomfortable to do that for the patient without local anesthetic. So I would suggest that you're more gentle and you're probably less effective in its removal. So I have a ballpark figure. If a patient has got 5 millimeters of probing depth, then I will not debride it without sticking a needle into it. I will make sure that they are numb. And you can see on this photograph here, there's a huge amount of inflammation that this patient presents with. Now, to be frank, this is probably uncomfortable to probe, let alone debride. So I would emphasize that time and local anesthetic is absolutely essential when you have this degree of bone loss, this depth of pocketing, and this amount of inflammation. You can see from their 6-point pocket chart that they have very deep pockets and a huge amount of bleeding that's present. And you do need time to actually get into all of those pockets throughout the whole mouth. What do I use? I use a combination of hand instruments and ultrasonics. The hand instruments that most periodontists use are Gracie curettes. Now, the thing about Gracie curettes is they have one cutting edge. They're not universal, so they have to be used in a very specific manner. And once you're used to them, I think it's pretty hard to use anything else, but they're not universal and you need to get the right curette in the right area. So there is a different curette that you would use for a mesial, distal, buccal, anterior and posterior surface in order to effectively remove the calculus better. At this point, I would like to thank my ex-hygienist Kirsty for some of these wonderful slides. Thank you, Kirsty. Which curettes do I use? I have really a very small tray of instruments when I see a patient. I've got a mirror, I've got a UNC 15 probe, I've got 4 Gracie curettes, which are the 1-2, which does my anterior surfaces, the 9-10, which does my posterior buccal and lingual surfaces, the 11-12 does the mesial surfaces, and the 13 and 14 uses distal surfaces. There are other ones that are available that can also cover those, but they just make sure you're using the right one in the right area. And also the bottom picture is essential. You must sharpen them, and you must sharpen them correctly, because once they're blunt, they really, really don't do very much. It's not easy. It's not easy to remove calculus, subgingival calculus, particularly tenacious calculus that's been there for a long time. And it's quite easy to feel like you're removing it, but you're actually just chipping off the top few layers. So you need a variety of different stroke directions: vertical, oblique, horizontal, getting it all around, but just going in one movement, you're unlikely to remove all of the calculus effectively. So I take these 3 directions quite systematically in my head. And similarly, if I'm trying to do a molar, then which has a furcation involvement, I have a very systematic way that I follow it. I will start with 1, the band 1, where I use the mesial and distal curette just onto the root trunk. And then I will take each root separately, starting with the distal surface of the roots with a different Gracie curette, then move to the mesial surface of the roots with a different curette. And I will end into the actual, what I call the belly of the furcation, just getting underneath there and really systematically envisaging it with your mind, because a lot of this is it's a blind procedure, right? When you're underneath the gums and it's, non-surgical debridement, actually you're going by feel. You can't really see what's going on. I will then move on to ultrasonic curette, so ultrasonic instrumentation. I always start with hand curettes and then move on to ultrasonic. I know that a lot of the hygienists that I've worked with do it the other way around. It makes no difference, whatever works for you. The reason I start with hand curettes before moving to the ultrasonic is I feel like I get a lot more tactile. I can really feel the roots a lot better with the Gracies. Also, I'm testing the anesthesia, and if they're still jumping around, then I need to put a bit more. I'd rather test it with a hand curette rather than ultrasonic, which could be a bit more uncomfortable for the patient. And also I feel like I remove more granulation tissue with the hand curettes. And that reduces my bleeding and helps my visibility. So that's why I start with the Gracies before moving to the ultrasonics. The ultrasonics I use are very simple, very, very straightforward. I use a Cavitron, I use the slimline insert, a straight, and a left and a right curved, which are wonderful for getting into the furcation. So it's a simple Cavitron, fine ultrasonic. So this is back to the same patient. You can see the before pictures on top, and you can see what this patient looks like after they've had some non-surgical debridement under local anaesthetic. Now, to our trained eyes, the bottom picture is wonderful. It's the epitome of health. The tissues have shrunk back to health. They're not red, swollen, inflamed. The calculus isn't visible, and it just looks much, much healthier. The reason I've particularly shown this slide is there's one thing you must remember before even picking up your first curette, and that is consent. Because to us, that looks beautiful, but to patients, they are not going to thank you for black triangles and roots on show unless they're consented to be aware that this is what is happening. And I think it's absolutely important that we discuss consent with them for recession, black triangles, for dentine sensitivity, and encouraging them to be consented to come back and have supportive periodontal therapy on a 3-monthly basis. So I'm now I want to get you right up to date. So the British Society of Periodontology have developed some new treatment guidelines, and this is hot off the press. And thank you to the BSP for allowing me to share their slides and from their webinars as well, particularly to Nicola West and Ian Chappell, who've given me permission to share from their webinar and from the British Society of Periodontology website. I might call it BSP now. Now, what they have done is they've developed these S3 treatment guidelines for periodontitis. And what that means, it's the highest level of evidence, scientific evidence, clinical relevance, benefit and harm, ethical, legal, economic, all of these considerations, as well as patient desires. And the idea is to actually give us some clarity and consistency so that perio treatment in practice becomes less wishy-washy and we're all following the same guidelines along. So you will find it on the BSP website under professionals, and I've just highlighted that with an arrow there. So when you go into that, you can either read this extremely long article on the left-hand side, which covers every single guideline, or may I direct you to their free webinars. You do not have to be a member of the BSP, where they cover all 4 steps over 4 webinars, and they are brilliant. And, you know, I'm not even a member of I'm a member of the BSP, but I'm not on council. So I'm plugging them because I genuinely think what they've done is absolutely fantastic. And you can find all of this, like I said, free on the BSP website. What the BSP did was do something called a grade adolpment. That's not a typo, it's a new word, a grade adolpment framework, which basically means they took all of the framework from the European Federation and they adopted it, adapted it, and added their own developments to make clinical recommendations that work very well in Great Britain. So it's a grade adolpment, and they did this for every guideline. They have got a recommendation that's either strong or recommended or open, and then you can see the consensus of that as well. So let me just show you a couple of examples of these guidelines, because these are going to become the norm. It's important that you become familiar with these. So, for example, they asked a question: what are the adequate oral hygiene practices of periodontitis patients in the different steps of periodontitis therapy? And what they did is they give a recommendation here. The evidence-based recommended is adopted. We recommend that the same oral hygiene guidance to control inflammation is practiced throughout the 4 steps of therapy, including supportive periodontal care. And I'll come on to the different steps. They gave that a grade A, so it's the strongest recommendation with the highest consensus. Now, this one's fairly obvious, but not all of them were as obvious as this. For example, they asked the question about lasers, and is lasers therapy superior to non-surgical subgingival instrumentation alone? And again, they give very clear answers. We suggest that lasers are not used as adjuncts to subgingival instrumentation. They gave that a B, and they literally, this is a majority, so it's not recommended. And so it's extremely clear. And they took into account things like economical factors and accessibility, because how many people have access to lasers? So it was important to take those kind of patient considerations into consideration as well, and the cost. So Professor Ian Chappell did this incredible acronym called PRICE. So these are the steps that the BSP have now recommended that we all adopt in treating our periodontitis patients. So PRICE. P is step 0, and this is your prerequisite before you're starting any therapy at all. We're educating, we're diagnosing, we're risk assessing and putting a care plan together. R is your step 1, and that's your risk factor control. We must get their oral hygiene great, like we discussed earlier, give them some adjuncts if they need to. Here's the new one, PMPR. You're going to hear a lot of this word. PMPR. Oh, sorry, I need to get back to that. What did I do? No.
No problem.
Sorry.
That's okay. So we will just stop that at the moment with the screen share. If you go, if we...
Sorry, I got a bit overexcited.
No problem. That's okay. Right, cool. If you do screen share now, if you go to your PowerPoint, you can close the main video, the main big PowerPoint, and then screen share again from current slide. It should work pretty okay. For those of us listening and going through this, if you get any questions, if you have any questions, please feel free to put the questions down in the box below. If you go to PowerPoint for me, Gita, on the bottom, a bit further down from WhatsApp, down, go right to, yeah, that one. I think that's, yeah, there we are. We can see that. Now click on slideshow, or yeah, start from current slide. Yeah, perfect.
All
We can
right,
see
sorry
that.
about that.
That's okay. Excellent. Thank you. I think she just wanted to show us a picture and of the world famous Bobby Bandlish, who is her absolutely awesome husband as well. But there we go. Let's go for that.
He
Thank you.
wasn't my inspiration, remember? That was my father-in-law. Sorry about
Absolutely.
that, guys. IT is so not my strong point. So PMPR is what I wanted to highlight, and that is professional mechanical plaque removal. And this term has superseded all the other terms that we have ever used for root planing, debridement, non-surgical debridement, scaling and polishing. It's all PMPR from now on, which is professional mechanical plaque removal. This is recommended by the BSP, and PMPR can either be supragingival or subgingival. So step 2 is to intervene and actually remove the subgingival biofilm. Step 3 is C, which we check and review. And step 4 is your exit plan. So this is your supportive periodontal care, rehabilitation, or extraction. So how do we put this into place? We do this in this stepped approach. So it's very clear that we start off with our examination diagnosis, and then we move to step 1, which, as we know, is to control our local factors and risk factors. Here we go again, professional mechanical plaque reduction, PMPR comes here, and that is supragingival here. If we get adherence at this point, in that their oral hygiene improves, they reduce their smoking, they improve their diabetic control, we can at that point move to step 2, which is when we do subgingival PMPR. If you still have periodontitis at that stage, we need to be moving to step 3, which is when we're considering periodontal surgery and often a referral at that point. And finally, step 4, which is supportive periodontal therapy carried out professionally. BSP have produced this in guidelines in a chart, much like they did the classification. They are sending these out to every single dental practice in the country and every single dental hospital. So there are the 4 steps. It's very small here, but you can find it on the BSP website. Like I said, you'll be receiving one in the post from them anyway. It's laminated so it can be wiped clean. And the 4 steps are outlined here in this flow diagram, step 1, 2, 3, and 4, so that we're actually making it very consistent in the way that we're treating periodontitis out in practice. Patients are now deemed to be either engaging or non-engaging, and this determines whether you move from step 1, which is supragingival, PMPR, to step 2. If a patient is deemed non-engaging, in that their plaque levels are still over 20% consistently, their bleeding's more than 30%, and we haven't controlled the smoking and the diabetes, we need to keep them at step 1. And the reason is that we know that none of our subgingival debridement is going to be effective unless these other factors are controlled by the patient themselves. One more thing that I want to highlight on the BSP website is this Healthy Gums Do Matter toolkit. For those of you that haven't seen it, again, it's free access. It's an absolutely amazing document. It's massive, don't get me wrong. It's got over 130 pages, but it is like a practitioner's toolkit. There's nothing about treating periodontitis in practice that is not within this. And it's a really easy, accessible, clear, well-written document that's really excellent for all practitioners out in practice. And one of the things I particularly like, and you can download these free from there, is they've produced these patient agreements, almost contracts. So there's a gum health one that you sign and the patient sign that basically says they're going to come regularly for their treatment and improve their oral hygiene at home. Similarly, there's one for periodontitis. And again, you sign this contract with your patient just to try, it might just act as another motivational tool to get them to actually engage in this. So if we go back to my top tips, we want to try and control the risk factors that we can. We have a very delicate balance between host and bacteria. And there are some factors that we can control and there are some factors that we can't. So we can control their oral hygiene, or at least we can try to. We can encourage them to have their regular supportive care with ourselves or our hygienist. We can discuss with them smoking cessation. We can explain why good diabetic control is absolutely essential. We can ask them to lower their stress because stress reduces their immunity, and periodontitis is an infectious disease that is, literally goes wild when your immunity is lower. But we can't control the genetic predisposition. That's the one we can't control, and that's the one that's hardest to fight. So how do I talk to my patients about smoking? Pretty openly, actually. I kind of start with the soft line, like, I'm not here to lecture you, but it is part of my job to explain and educate to you what smoking is doing. Smoking is a major risk factor for gum disease. And importantly, it also reduces the treatment success. So if you're going to spend the time and effort and come for all this treatment, you need to know that it will be less successful if you continue to smoke. Another analogy I often say to my patients is the surface area of your gums is the same as the palm of your hand. Now, if the palm of your hand was completely covered in infection and pus and it was bleeding, you'd be really quite concerned. So why would you think bleeding gums is okay? Right? So you'd be concerned, and you could actually see how it would be affecting your general health. Now, the closest systemic relationship we have is with diabetes, and that is bidirectional. So what I mean by that is if you treat the periodontal disease, you're actually lowering your glycated hemoglobin in the blood, known as your HbA1c level, and you're actually improving your diabetic control. Now, that's amazing. Treating periodontitis improves your diabetic control, and improving your diabetic control improves your periodontitis. When it comes to the coronary heart disease and preterm low weight babies and dementia, we do need more trials. We know that there is a link between periodontitis and systemic health. Oral bacteria have been found elsewhere in the body after traveling systemically. And I'm saying, I'm not trying to scare you, but I do have to inform you that there is a link. But equally, we do need some more interventional trials to establish whether treating periodontal disease actually improves cardiovascular disease in preterm low weight babies and dementia. Patients see this and they think they're going to lose their tooth. That's what most patients will say. They won't say, I'm worried about sensitivity or even the recession per se. They're like, it looks like I'm going to lose my tooth. And I will say to patients, actually, you've got bone mesally, distally, and lingually all the way around this, and you're not necessarily going to lose your tooth because you have a bit of recession around there. But in this case, if it's post-orthodontic or it's exacerbated by toothbrush trauma, there are a few things that we can ask them to do to try and reduce the toothbrush trauma in that area. Before I would even consider doing something like a mucogingival gum graft, I need to make sure there is no toothbrush trauma that's exacerbating this. So here's some top tips about what I do for patients that have toothbrush trauma. Okay, most patients are right-handed. Start brushing on the top left. Bit more vigorous there. So start brushing in a different part of your mouth. Change the way you hold your toothbrush. So most patients hold their toothbrush in a fist grip. I ask them to hold it in a pen grip. It's much lighter on your bicep and you're more gentle with your brushing. Change your toothbrush head every 3 months. Surprising how many people don't do this. Once the bristles have splayed, you're actually polishing your plaque rather than removing it. If you still feel like you're pushing too hard, get an electric toothbrush that has a pressure sensor. And if you're using an electric toothbrush, hold your hand still. This is vital. So if your toothbrush, if we take an Oral-B, for example, which is rotating and oscillating like that, if it's going round and round and round and you're also brushing and you're not holding your hand still, you're effectively double brushing. So it's very important with an electric toothbrush, they learn to hold their hands still. Now, we know recession is often unavoidable and it might be desirable for us, but not necessarily for the patient, because they get recession and sensitivity. Now, sensitivity is subjective. And just because the gums have shrunk back and the teeth are more exposed and the roots are more exposed, it's very personal. So you can have a patient with a lot of recession that has no sensitivity and a patient that has very little recession that has a huge amount of sensitivity. I explain it to patients that gums recede as the tissues are shrinking back to health. That's what it is. Gums are going to recede anyway as part of the disease process, and I literally say that, but this way we're trying to control it. Now, for us, recession's a good thing. An interdental brush is going to go maximum 3 millimeters subgingival, so I'd rather that there was clinical attachment loss was in recession rather than pocketing, because this is much more accessible for a patient on a day-to-day basis. Consent for recession. It's really important. In these cases where we've lost bone, gum grafts are unlikely to be a feasible option, but you can consider gingival veneers or pink composites at the neck of the tooth, and obviously good quality dentistry to close the gaps elsewhere. Recession is unavoidable, particularly if you're having surgery. This is a post-surgical case. We do have techniques around like papilla preservation flaps to minimize it, but in resective surgery, certainly you're going to get more recession. That leads me to surgery, which is a scary word. And I'll mention surgery to a patient as if it's something they should aspire to want. And they're like, gum surgery. Now, the reason surgery is scary is because it involves things like scalpels, right? So I will say to a patient, all it is when I'm doing the deep cleaning to begin with, it's a blind procedure and I'm going by feel. This is the same deep clean, but the gums are open. It's an open procedure. So I'm just trying to explain it to patient and just take a little bit of the fear of the word surgery out. If I am doing surgery, or even with non-surgical patients, post-operative instructions, of course you give post-operative instructions, everyone does. I tend to hype it up, particularly if I've done surgery. I don't know their pain threshold. Everyone has different pain thresholds. Some patients will say to me, I felt virtually nothing. I took a Nurofen on day one, job done. And you get some patients that come back a week later going, no, it's really still quite sore. So as you know, if you say something before, it's advice. If you say something after, it's an excuse. If you tell them it's really going to hurt and it doesn't, you're a hero. If you tell them it's really going to hurt and it does, well, you tell them that it's going to. I don't give, as a general rule, any prescribed painkillers. I will stick to paracetamol and ibuprofen if they're non-asthmatic. A combination of the two, either alternating or together, is excellent. An ice pack or frozen peas down on the bottom left here helps to keep down any swelling. Corsadil is fantastic post-surgically because it prevents plaque sticking to a clean surface, and post-surgery it's a clean surface, just to be used for around a week or so. And I'll tell patients when it comes to the pain meds, it's like when you've got a headache, you need to keep on top of the pain meds. If you've got a throbbing headache, they're not that effective. If you take the paracetamol or ibuprofen just before the headache's fully established while it's coming on, they're excellent. Dental pain's exactly the same. Keep on top of the pain meds for 48 hours minimum and then see how you feel. And it's going to feel worse before it feels better. It's as simple as that, but then it will feel better. I'm going for long-term love, not short-term. Another term that I use for patients, which I think is they understand, is some of your teeth have got a terminal prognosis, right? So all this treatment we're having, I'm trying to get you to come every 3 months. I don't want them to turn around and go, why did I come? And I still ended up losing my teeth. The bottom line is I'm trying to prolong the loss of your teeth. I can't save them. They have a terminal prognosis, and we are providing palliative care. And that kind of expression is something that patients really can get to grips with, and it's terms that they're familiar with. So I use it very often to explain to patients when I think their teeth have got a hopeless prognosis, but we're not quite at the extraction stage. The other thing I tell patients is what's gone is gone in terms of bone loss. And yes, there are a few examples where in small cases we do regenerative surgery, but generally what's gone is gone. And I will explain to them that if you don't have a tooth out that I think needs to be extracted, teeth share bone. So the interdental bone between two teeth, if you don't lose that tooth, you're continuing to lose bone on the tooth behind it. So it is having a domino type effect. If we're recommending you lose a tooth, there's a reason why we're recommending that you lose it, because otherwise you can literally, it will just move along as you're losing the interdental bone between. This patient, for those of you that are interested, is someone that I saw back in my Eastman days a long time ago, and he had Papillon-Lefebvre syndrome. So he was a young guy, and his teeth were simply erupting and exfoliating at the same time. It was fairly heartbreaking. So Patients come in with drifting anterior incisors all the time, and they want orthodontic treatment, they want restorative treatment, but, and I will say this same line, we need to build a house on healthy foundations. The gums and the bone is essential. If that is not healthy, then we can't build on it. You should not be having orthodontic treatment. You should not be having restorative work until we have stabilized the periodontal disease first. I said, we can do it all. We can do ortho, we can do restorative, but we need to build that house on healthy foundations. And the reason for that is because bad dentistry, even all dentistry, causes dentistry. If we're producing restorative work that has overhanging margins, this is impossible for the patient to clean. These, in this top picture particularly, you can see the crown margins are impinging upon what we used to call the biological width, but the new term for it is the supracrestal attachment. So we need to carry out good quality dentistry, because even good quality dentistry is harder to brush than a virgin tooth, because it's it's going to be plaque retentive. So dentistry causes dentistry. But we can do good quality dentistry and keep our margins cleansable. This was the case that we saw earlier, and she's got some beautiful veneers there that's aesthetically miles, streams ahead of the where she ended up post non-surgically. So that looks beautiful, and you can see that she's going to be able to clean around those margins extremely easily. What about those patients that have periapical areas, they're chronic infections, they've got no signs or symptoms whatsoever, and you don't think that the tooth is savable? When a patient refuses to have these teeth taken out, and that's their prerogative, right? We just have to consent them for what might happen. I will describe it as a time bomb waiting to go off. And the problem with this time bomb is I don't have a crystal ball either, and I can't tell you when it's going to go off. But I'll often say it could easily be on Christmas Day in Thailand, back when we were allowed to travel. So, you need, by not having this tooth out, you need to understand that you could be in an acute emergency situation. And I think this tooth's got a hopeless prognosis, and it should be extracted, despite the fact that you have no signs and symptoms from it. Okay, I use this all the time because, as you know, patients come in and they have Dr. Googled everything. I'm like, oh, Dr. Google, he's a really dangerous doctor. And look, I know we all do it. We all Google our signs and symptoms, but we can tell by looking at this large swelling on the upper right 2-3 that is most likely to be a fibrous epilus and not a squamous cell carcinoma. But if you Google lumps on gums, you are going to get a plethora of diagnosis, from the innocuous to the pretty damn scary stuff. Now, in this case, it was a fibrous epilus, and removal of that alone is going to unlikely to cause it to stay away, because it will recur, because there's usually some subgingival calculus underneath it. So removal of the epilus must involve removal of the subgingival calculus at the same time to prevent recurrence. Clearly, in this case, you need a full mouth debridement. The other thing I've noticed about Google, and I definitely think this has got worse since lockdown, is I get a lot of referrals for periodontal treatment and implants in my practice from dentists, but increasingly I'm getting quite a few from Google, where patients, I guess, are Googling gum disease London or gum specialist, something like that. And I'm getting a lot of psychosomatic illness at the moment. I'm getting a lot of patients that are coming in with very little organically, pathologically wrong with them, but are convinced that all their teeth are going to fall out, and are convinced that they've got very advanced gum disease, are convinced they've got a ton of recession when they really haven't even got anything that's measurable. I wonder if you guys are having the same in practice. There's obviously a lot more clenching and grinding with the stress we're seeing, but I've certainly got a large number of patients that are coming to see me where I'm like, please just go and see my hygienist, have a nice scale and polish, sort everything out, and you're fine. You don't need to have any advanced treatment. Okay, here's my other analogy. So if a patient has an implant, I tell them that they have a Ferrari in their mouth. And if you have a Ferrari, you need to service it. So this goes back, and I've said it all the way from my very first slide, regular supportive therapy with yourself or your hygienist on a 3 to 6 monthly basis, depending on the clinical signs and risk factors, is absolutely important. And I would say an implant is a Ferrari, service it. You wouldn't just stick it in your garage and never service it. Right, coming towards the end now. So if you engage in the treatment, you marry the outcome. Thank you for these words of wisdom from my colleague, Martin Kelleher at King's. Now, I think what we mean by that is it's very important that once you pick up your drill, your curette, any kind of treatment that you do, once you engage in the treatment, you own that outcome, you're responsible for it. So if it is outside what you feel is your scope of practice, or quite frankly, just your comfort zone, refer, refer, refer. So that's what I mean by that, particularly with the number of psychosomatic things that we've got going on. Often treating the mouth is relatively simple. Treating the patient as a whole, much, much more complicated. So either refer if it's outside your comfort zone, or use something like dentinal tubules. It's got lectures on everything. It's got CPD on everything. Get on your WhatsApp groups, speak to people, and just really, before you're engaging in the treatment and marrying the outcome, make sure you know what you're doing. And finally, my last slide. To me, this is the most important slide of what I've learned in the last 25 years as being a dentist. I think times are hard. Times have been very hard in the last year. And in all my years of teaching and treating patients, the thing that is most important is that we look after ourselves and we put our oxygen mask on first. Because if things are going okay with us, and we all go through stressful times, family illnesses and so forth, if we can cope with what's going on with us, then we are much better able to cope with what's going on at work and to help others. So look after yourself, stay safe, stay healthy. Thank you for listening. And I'm very happy to take any questions. If you have anything after the webinar, please feel free to contact me on my personal email address here.
Thank you very much for sharing those really cool tips. I like some of the lovely analogies as well. It kind of puts things into real perspective as well. The journey of the patient, so important. You've shared a lot of the recent updates as well, which is so useful for people. We haven't had a new classification in the last couple of years, which the BSP then adopted for the UK as well. We've now had the S3 guidelines, and the development process has happened as well. It was very interesting. I saw that word the first time and thought, and then I realized it is a real word. So cool. Now, as everyone's catching up, please feel free to post your questions in the box below. But I'm really going to start, the question really at the beginning, what I call the step one, and the communication process. How long's your time and appointment to kind of do the diagnosis, the initial assessment, and really getting the patient on board in that first appointment? Do you really have to, allocate a fair amount of time for that?
I'm very lucky because in private practice, I have the same amount of time that I do at King's, really. So it's the best part of 45 minutes to an hour. I think if you're going to be doing a 6-point pocket chart, taking a full history, a full examination, all your x-rays, establishing a diagnosis, explaining to the patient, because like I said, communication is key. There's a lot of talking that goes on in a new patient consultation so for them to understand their disease process, even if they have been on Dr. Google. I think, for me to relay what I think is where they're at and how they can move forward. It does take time, and I understand in the NHS that's you always have the benefit of having that much time. But I would say to do it properly, 45 minutes is about the minimum you need.
I think the other thing here is that I suppose that first appointment isn't just enough. I mean, even if you have 45 minutes, you have an hour. It's not the be all and end all. Periodontally, it's a journey. So every time your patients are getting a bit more information, they're getting a bit more of whatever you're telling them or giving them as well. What if they reach step 2 and the plaque control still over 20%? Is it a rule of thumb for you to say I'm not progressing on, or do you think that some of them you would progress with RSD? My thought process, I normally go on to the stage 3, because just doing the treatment somehow, for my patients, it somehow brings them motivated even a bit more for whatever reason. It might be that they're paying, it might be that they're seeing a change. I don't know.
I would agree. The British Society of Periodontology are saying that you really shouldn't be moving to step 2 unless you see some improvement in bleeding and plaque scores. I do think sometimes if you've got that degree of inflammation and you've only done some supragingival scaling, perhaps there's still quite a lot of soreness and discomfort, and actually doing a bit of subgingival debridement would be quite useful because that will reduce that inflammation and again motivate them and help them. It is a legally robust document, that's what they're saying, but I think it's fair to say that in private practice, if you're not doing anything subgingival, I think it's going to be a little bit tricky if someone's paying for a 45-minute session with a hygienist and they're not cleaning below their gums. It's arguably you're not getting what you're expecting from that appointment.
And I think that is also important because I come back to the whole system difficulties. That step 2, it just lets you adopt that really well, because if somebody's not improving, you can see them 3 months later, institute another element of cleaning as well. Interdental cleaning, let's move one step further. And how easy do your patients find adoption of interdental cleaning? It's a manually dexterous thing. Not everyone gets used to that kind of manual dexterity overnight. And what's your patient's kind of approach to it that you found in your experience?
It's a bit of a tell, show, do scenario, actually. I think, you're telling them what they need. You're showing them on a model. You're then showing them in their mouth, ideally, and then you're getting them to do it and just modifying what they're doing. I don't really want them popping a little brush above the papilla. I want them to try and get it both sides of the papilla as subgingival as they possibly can. Can every patient manage it? No. And sometimes you have to accept that's the best they can do. That's as dexterous as they are. I certainly think interdental brushes are easier to use than floss, much less fiddly. So it's...
It is so true about... Hello?
Hi, you're frozen.
Yes, can you hear me? Sorry,
yes,
I froze for a moment there. Yes. So there, thank you for a nice presentation. Louise Norwell, again, thanks you for a really reassuring update. It's encouraging that we're finally being encouraged to all be on the same perio page, which is so good that Louise says that. And Lean Boo says, thank you, Geeta. Very informative webinar with great updates and tips on delivering information to the patient. Now, if we move on to the root debridement or the root planing or whatever term someone prefers on their basis, I like my hand instruments. I've always been a fan of hand instruments. I know we've not been able to fully utilize AGP-inducing ultrasonics during the COVID era. Do you find you use one in preference to the other fairly often? Do you find they use them equally? Do you have choices of which ones you use where?
I think I do about 50-50. So if I have an hour debridement, I probably use my hand cuvettes for 50% of the time, and I use my ultrasonics for 50% of the time, because I just get that tactile sense. I like removing the granulation tissue. I really like the reduction of the bleeding that I get from that. And then I'm going back in with the ultrasonic, and then I kind of go back to my cuvettes as well. I'm just trying everything, because experience has shown me that removing calculus is not that easy. If you're going down a 8-9 millimeter pocket on an upper or lower molar with a furcation involvement, that's not easy. You've got to throw everything at it and take some time, numb it up, get underneath there. I'm a big fan of local anesthetic. I think
that's very, very important. I hope people take that on board. Now, has the new guidelines, Zara says, thank you, Geeta, excellent and informative presentation. We're glad that you're relaying this knowledge. With the new guidelines, has it changed the way you approach things in your practice? Has it modified the way you approach certain things in practice?
I think the best thing about these guidelines is there's nothing spectacularly new about what they came out with, but it is the first time it has been done that it's in black and white and it's very clear. And so it gives you confidence that all the things you've been saying to your patients and, oh, actually, this is as good as that. And that's what it just gives you the impetus, go, right, okay, that's what the guideline is. I absolutely want to follow that, and I've been doing it right all along. And because so there's nothing, I don't think you'll read it and think, oh God, I didn't know that, but you will be very reassured that you were doing it right.
And I think it structures it nicely for you. That's the other thing I tend to find. So I'm really good for that. Rachna is talking about what's your opinions on water picks?
Oh, that's an excellent question. So as part of one of the guidelines, they discussed this, the effectiveness of water picks, and hot off the press in that guideline is they can be used adjunctively. Okay, but they're best placed to use adjunctively in areas that you can't use interdental brushes. An interdental brush would be preferable. If you want to use a water picket as well as, I would say it's a bit like the perfume and shower, you can use it at the end, but don't use them instead of interdental brushes. The only time I would say you would use them instead of interdental brushes is if you can't get an interdental brush in. For example, linked implants and so on and so forth. You want to get something underneath it. Something is better than nothing. So they have their place, but I wouldn't use them as an alternative.
And then Libby Hendry says, thank you for a practice usable presentation. And I think I agree, very good and practical. Tejas is saying, when would you consider referring patients to a perio specialist?
Okay, so that would be at between step 2 and 3. So you have carried out your step 2, which is your subgingival PMPR under local anesthetic or your root surface debridement. You've done your full mouth deep clean, you've reassessed it and there's still some deep pockets and you don't feel like you would get any further resolution from another round of non-surgical debridement by yourself, and you feel that surgery or specialist level would be required. So I would send it at that stage after you have tried a round of non-surgical debridement yourself under local.
Yeah,
unless you think it's very advanced at the beginning. If they're a grade C, you could argue that's not, you can just go from the get-go because you know that they're highly susceptible as well.
And I suppose the old aggressive cases are pretty much worth looking at, younger patients. I've also posted a link there, Tejas, in the chat of somebody who had kind of done a lecture we filmed about when to refer to a specialist. If these put a link for the CPD version as well. Nimlita talks about how exactly should patients be asked to use chlorhexidine. Is it mandatory after non-surgical root debridement? And any alternatives for patients with a history of allergy to chlorhexidine?
No, it's absolutely not mandatory at all to be using it adjunctively. If patients, I rarely recommend it. I would say that I would use it post surgically where the patient can't brush, or if someone is a grade C and they have like what we described as a highly aggressive form of the disease, you could argue that they can use it on an interdental brush or using a mouthwash with it. It is not a strong recommendation, but it has a role adjunctively. But for your general, what we used to call chronic periodontitis cases, it doesn't really have a role.
It doesn't add much to that.
No.
I tend to use Curacept, which is also an alternative, but it doesn't stain the teeth. So that's definitely worth thinking about.
Yeah.
Michelle Coles kind of comes in with the sort of angle of, is it worth investing in things like guided biofilm therapy or air polishing, such as the EMS system? Have you adopted any of these things in practice?
No, we haven't, but I know plenty of practices that have. I would say the evidence that they're doing anything different to what you would do with your conventional therapy that we discussed isn't there. That doesn't mean that patients don't like it, or it's quite a nice selling tool if that's something that you want to get into. But in terms of investment, if you're actually looking for a clinical improvement that is evidence-based, it's not there.
That's right. And I think also it's the patient motivation. So Aphrodite says, thank you. Another excellent webinar. Good to see you back, Aphrodite. Romika talks about the airflow, which we've just answered, and enjoyed the presentation. And Rachna says, enjoyed the presentation. And this, I think, summarizes it in the best way, Geeta. It simplifies how you do perio in general practice. You've really put a roadmap for people to think about. That's what I enjoyed today. The story is good, the tips are brilliant, and really telling them, forget Ferraris and looking after. What you've delivered today is a level of presentation which I think even a Ferrari wouldn't match. It's just so well sorted. So thank you so much for sharing that. It approaches 9 o'clock. If you do have any further questions, feel free to pass them on the chat below or email Geeta at her email address. But I hope you've enjoyed this evening, and thank you, Geeta, for sharing the time with us. Leaves me to say one thing. Normally, when we're in Tubules Live, at this point, we would be throwing the Tubules t-shirt to you. But we normally said Tubules. It's because you don't just teach, you inspire. And I think the comments today have shown that. So when we see you next, we will get the t-shirt out to you. You can wear it with pride. And I think Angela's got to get one as well. So maybe on the golf days, you two can have one side by side.
Yeah, we'll be together.
That'd be brilliant. So thank you so much for sharing your time. Thank you everyone at the audience who've enjoyed this as well. We will see you Thursday, 7:30, the Class 2 Matrix. If you haven't seen the video trailer for that, it's worth watching. But for this evening, it's goodbye from me and a good evening from Dr. Geeta Alplish and sharing her tips. Have a great evening, everyone.